of the HFG project. It's my sincere pleasure today to be joined by Dr. Kamalia. Dr. Kamalia has over 25 years of experience in the public health sector in Malaysia. Currently, she's an associate professor at Cyberjaya University College of Medical Sciences. Previously, she headed the primary healthcare section of the Family Health Development Division in the Ministry of Health. Dr. Kamalia is a technical facilitator for two technical initiatives under the JLN, one on primary healthcare and another on provider payment mechanisms. We're also fortunate today to be joined by members of the JLN's Private Sector Engagement Collaborative, which you'll hear more about. They come from Ghana, Indonesia, Kenya, Malaysia, Mongolia, and Morocco. Each of these countries is striving to engage its private sector to achieve universal health coverage. Specifically, we'll share videos recorded by representatives from 3 of our JLN countries. The videos highlight insights about the stewardship of the private sector in these countries. Other JLN colleagues will be on the line for the Q&A portion of the webinar. So from Malaysia, we'll hear from Dr. Shafi. He's the head of sector, primary health care, clinical and technical support in the primary care section and family health division of the Ministry of Health in Malaysia. Next, we'll hear from Julia Oku, who is a senior benefits officer with the National Hospital Insurance Fund in Kenya. Our third video will feature Rizki Talashita Mahardia. Rizki is a researcher with the Center for Health Financing and Health Insurance Management at the University of Gadjah Mada in Indonesia. And just to note, throughout the webinar, I think I've already started doing this, we'll refer to the Health Finance and Governance Project as HFG and the Joint Learning Network as the JLN. When we speak about universal health coverage, we'll use the acronym UHC, and you'll also see the acronym PHC, which refers to primary health care. So we'll begin today's webinar by discussing the importance of engaging the private sector in primary health care for UHC. Next, we'll introduce the JLN's Private Sector Engagement Collaborative and its work so far. We'll share information about the joint learning methodology for developing knowledge products and applying them at the country level. And finally, we'll share 3 new resources that, from HFG and the JLN that can be used by country stewards who are working toward UHC. I also want to mention that, again, we'll have 3 videos from country experts coming from Malaysia, Kenya, and Indonesia. And they'll highlight key lessons learned and innovations that are detailed in these new knowledge products. And then finally, we'll open up our discussion for Q&A so that we can dig deeper into some of these lessons learned. As countries make progress toward UHC, they recognize that the public sector alone can't provide all necessary services, including essential ones for primary health care to everyone, and that the private sector is an important source of care. In particular, primary health care is vital to equitably improve health outcomes and to achieve UHC. Countries need to effectively engage with and steward the public and private components of their health systems. And this requires careful balancing of government and market forces. Countries require public capacity to enable and oversee their entire health system, and the private health sector has to be organized and prepared to engage with them so that it can provide quality and fairly priced health services. Ultimately, public-private engagement supports UHC. It reduces out-of-pocket costs, it increases access to services, increases equity in access to those services, and improves quality. However, this balance is not so straightforward. Healthcare policies in most lower and middle income countries focus largely on developing government-owned and operated health facilities and a salaried government-funded health workforce. In contrast, there are fewer policies that have been implemented to enable and oversee the provision of health services from private health providers. Usually, governments lack basic information about private providers, such as how many of them there are, or where they're located, and the range and the quality of the services they deliver. Private providers, for their part, often focus on providing curative services and offer only limited preventive or promotive services. The quality of services they provide can also vary, especially when the private sector is largely unregulated. Now I'd like to hand over to my colleague, Dr. Kamalia, to explain more about the JLN's Private Sector Engagement Collaborative. Dr. Kamalia, over to you in Malaysia.
Thanks, Gina. And following up from what Gina has said on the importance of engaging and stewarding the private sector, members of the JLN's Private Sector Engagement Collaborative have worked together to share experiences and knowledge on how to engage the private sector in their countries to deliver primary health care. And to help fill the gaps in guidance in this area, the collaborative is authoring a guide titled Engaging the Private Sector in Primary Health Care to Achieve Universal Health Coverage, Advice from Implementers to Implementers. And this guide is designed to be simple and pragmatic, offering steps that public stewards can take to navigate the complex factors surrounding public-private engagement. What's important is that the guide provides information on not only why the step is important, but also how to do it. And the collaborative has published the first 2 modules on initial communication with the private sector and provider mapping, and modules 3 and 4 are currently in development. Now, in working together to develop the 3rd module on provider and facility regulation, the members conducted a literature review and could find only a few examples of regulating private providers in the lower and middle income countries. And to help fill this gap, 6 JLN countries, namely Ghana, Indonesia, Kenya, Malaysia, Mongolia, and Morocco, chose to conduct country assessments on regulation of private primary health care using a standard methodology. Now, the Joint Learning Network uses a country-led participatory approach. One, in identifying a common technical challenge. For example, this private sector collaborative was identified as a focus area when countries use the PHC self-assessment tool. And then countries got together to collectively work to solve the problem identified, synthesized new knowledge from the sharing of experiences, and then adapting this knowledge within the JLN countries at first, and disseminating it to other countries outside the JLN. And some of the key benefits to this approach include strong country ownership, and it meets both specific country needs as well as contributing to the global knowledge base. It provides a space to analyze root causes. It builds trust, safe space, and a community of practice, and results in practical tools and knowledge products that can be replicated and shared. And it creates opportunities for responsive follow-up by partners. And together, the collaborative members developed a country assessment guide, including a standard methodology and scope for use by countries in developing the country assessments now available in the JLN website. Next, the 6 countries conducted their own assessment, sharing experiences with each other along the way. And finally, the countries formally shared their findings during virtual and in-person events with support from the technical facilitation team. Together, they extracted lessons and innovations from the individual country assessments to inform the synthesized learnings discussed today. The new resources introduced during this webinar are useful for countries interested in learning from and adapting country experiences and innovations in regulating private PHC. Users can also conduct an assessment of their own health regulatory system to better understand challenges and opportunities for improvement. Now, the resources include, on the left of your screen, is the regulation of private primary health care, lessons from 6 JLN countries, a synthesis of lessons and promising innovations on regulation of private PHC from the 6 country assessments. Now, to your right is the 6 country assessments from Ghana, Indonesia, Kenya, Malaysia, Mongolia, and Morocco. And the assessments document what types of regulations are in place, how the regulations are implemented, what outcomes are achieved by those regulations, and what developing and implementing such regulations. And in the you'll find assessment. The next slide, please. Some lessons and recorded videos to share their country's input. Can I have the next slide, please? So, as you can see on this slide, as countries shared their experiences from their country assessments during joint learning opportunities, they began to identify common lessons, as well as promising innovations that some of the member countries are currently using to help mitigate the challenges faced. Here, I will describe briefly some of the lessons learned, and the webinar panelists will then share their perspectives as well. Not all the innovations identified in this product will be shared today, and we encourage you to download the document to learn more. Now, the first lesson common to many countries is the overlap of regulations in their countries. This results in inefficiencies, many of which are more restrictive for the private sector. For example, a single facility might be required to be registered or licensed by multiple boards or agencies, which can result in multiple licensing fees. Now, the second lesson is that there's a lot of overlap of regulatory actor roles and responsibilities. This further increases fragmentation and inefficiencies in the system. For example, a health regulatory agency and a national health insurance agency may both be completing very similar credentialing or accrediting process for the same facility. Now, next, in some countries, the private sector has a perception of being regulated more than the public sector, and they perceive this to increase costs for them. However, most of the participating countries have found promising results from implementing incentives to regulate. While there are these innovations, most of the regulatory instruments are still the command and control mechanism that enforce sanctions. If I can have the next slide, please. I will continue with the lessons. Countries noted the importance of a strong integrated data management system to ensure efficient data collection and data use. But many noted the challenges with data management for performance monitoring, including the fact that private sector providers, they don't report data through government systems and databases. And I'm sure this is common to most countries. They reported a lack of human and financial resources for adequate regulatory enforcement, as well as inequitable allocation of resources among agencies. Several countries also noted limited knowledge about regulatory processes among enforcement officers, in part due to lack of training. And because of that, there's differing interpretations of regulations at the various levels of enforcement, and this results in delayed licensing for facilities. Finally, several countries also noted low public awareness of existing regulatory laws, resulting in patients lacking knowledge about their rights and about healthcare standards and prices they're entitled to receive. We will now listen to some of the specific country lessons and innovations shared by our country experts by video, starting with Dr. Shafi'i from Malaysia. If the video doesn't automatically appear on the right-hand side of your screen, you will need to click on the drop-down tab that says Panelists. Can we have the video, please?
Hi, thank you for inviting us to participate in this webinar session. We would like to share our important findings and recommendations from the survey on the perception of stakeholders with regards to the regulation of private primary care in Malaysia. We observe mixed perceptions, both positive and negative, towards private sector regulation. In this video, I would like to highlight on 7 items. And the first is on regulatory framework, second on system fragmentation, third on resources, fourth on the knowledge, data, innovation, and others. The last 2 will be shared by Dr. Rima. The first one on the regulatory framework, MOH is the main regulator for private healthcare sector in Malaysia. Majority agree that we have comprehensive laws and regulations to regulate the facilities, services, and providers for private primary care. Private providers perceive enforcement activities as micromanaging and unfairly regulating them. They have limited engagement in providing input to promulgate laws and regulations. And they would like to see more engagement and participation with stakeholders in establishing laws and regulations in the future. Second one, on the system fragmentation, there are overlapping of regulatory actor roles and responsibilities, which increase fragmentation and inefficiency in the system. For instance, various regulatory bodies have duplicative roles and responsibility and often create additional burdens for providers and facilities. And some of the enforcement office activities are not well coordinated to address duplications or inconsistencies. For example, local authorities might specify certain requirements for the building or a clinic that differ from requirements imposed by national level actors. And it has been suggested to have a single regulatory body and compliance unit, as well as separate role for regulatory and enforcement agencies. As for the resources, this is one of our major limitations for Malaysia, is the limitation in the resources to carry out enforcement, both financial and human resources, affecting effective regulation. The federal government includes a line item for regulation in MOH budget, but the allocation is usually inadequate for enforcement activities needed nationwide. And recently, the Malaysian Medical Council, the statutory body, was given full autonomy and expected to raise sufficient funds through fees to meet their operational expenses with little supplemental funding from the government. And an alternative mechanism and sources of funding should be explored to be able to provide required resources. The fourth one is knowledge and competency. Major stakeholders agree that there is still an issue on the competency of the enforcement officers and on the knowledge of the private providers regarding regulations. And some of the requirements of the regulations are subjectively interpreted by enforcement officers, and their interpretations are inconsistent between central and state regulators. And there is a need to enhance competency of enforcement officers and continuously increase knowledge among the providers on laws and regulations. On data, we also face challenges with the availability of timely and high-quality data from the private sector, particularly on the pricing, the capacity, and range of services provided by them. Thus, MOH must use centralized and integrated IT systems across both sectors for effective and efficient monitoring and evaluation.
So thank you, Dr. Shafiee and the Malaysian team for the sharing. Now that we have shared some of the lessons that countries learned from assessing their systems, we want to share some of the promising country innovations for successfully regulating the private sector to encourage quality and comprehensive PHC access for all. For example, we will hear from our colleagues in Kenya on their process for forming a national regulatory technical committee to streamline regulatory oversight to help address the problems of duplications in regulations and regulatory efforts across agencies. And Indonesia will speak about using purchasing as a regulatory mechanism, a process that Mongolia also shared. And Indonesia will also speak about strengthening data management for measuring performance. We will now hear from Julia from Kenya. As a reminder, if the video doesn't automatically appear on the right-hand side of your screen, you will need to click on the drop-down tab that says Panelists.
Hello everyone, my name is Julia from Kenya. Kenya is a country in East Africa with a population of 48.5 million people. So I've been requested to speak about Kenya's innovation under the Joint Health Inspection Framework. Now in 2015, Kenya, with the help of World Bank and USAID and both private and public stakeholders in health, came together and designed an inspection checklist, which was meant to grade all hospitals in the country and bring out their scope of services. So together in 2015, this was launched and it was developed with its guidelines. So in 2016, a joint team was formulated. Remember, the joint inspection checklist can be used by a joint team or can be used singularly by an entity or an institution or an organization that is interested in knowing the level and the scope of services of a particular healthcare provider. So a joint team was formed that comprised of representation from Ministry of Health, representation from health regulatory bodies in Kenya, all of them, representation from the National Hospital Insurance Fund, and representation from the county government. Remember, Kenya has a devolved system of governance. Therefore, having 47 counties, we technically have 47 governments, and each county has its own Ministry of Health, which looks into matters that concern health, human resource, health service delivery, and all hospitals under them. So this team went around in 2016 and assessed all healthcare providers in the country. Now, it's noteworthy that this checklist takes into consideration several dimensions, including administration, facility profiling, medical and dental services, health management information systems, patient safety. It also looks at products in medicines and healthcare. And finally, it grades you based on scores. For example, a score of below 10%, you are a very high-risk facility and you face prosecution and closure. If you score, for example, above 75%, you are a compliant facility and you are exempted from inspection for about 2 years. If you are about between 40 to 60%, you are given your warnings and you are inspected again in 6 months. So the Joint Health Inspection Checklist is a good checklist that brought together both public and private partnerships and gave us very good outcomes, the results of which are still being implemented by the National Hospital Insurance Fund. So we recommend joint health inspection in your countries. And so I want to say thank you to JLN and
Thank you, Julia, for the interesting description of Kenya's Joint Health Inspection Checklist. Now, this innovation certainly helps tackle the problem of duplication across regulations and across agencies. Next, we will hear from Rizky from Indonesia about Indonesia's innovations relating to contracting and using integrated data software for monitoring and management.
Regulation on private health providers in Indonesia has existed over 3 decades ago as the government became aware of the importance and challenges posed by private health providers. Over time, more regulations on private health sector have been introduced and regularly amended, adjusting for recent technological advancements and the dynamics of public policy. In this globalization era, several efforts have been made to promote effective private health sector engagement in the national health system. This is especially important since Indonesia has been working towards achieving the universal health coverage through JKN, or the National Health Insurance Program. A few examples of innovation in regulating private health sector engagement in Indonesia. First is to use purchasing as regulatory mechanism, and this has been done by contracting health providers. Under the JKN scheme, the Indonesia National Health Insurance Agency, or BPJS, has contracted private health facilities to engage in providing primary health care and purchase their services using commitment-based capitation to ensure the standard of care and to encourage the improvement of primary health care quality. Contracting is done through performing credentialing process to health facilities, and commitment-based capitation itself is the payment mechanism where capitation is paid using pay-for-performance approach. For instance, to be paid 100% of capitation, a health facility must satisfy criteria of all indicators. Second is to strengthen data management and data sharing across the public and private sectors using technology by standardizing data entry. To facilitate monitoring and evaluation process, information system management software has been developed using online platform and has been installed in all levels of healthcare, from health facilities to regional health offices and to Ministry of Health and BPJS. This is particularly essential, for example, to carry out credentialing and assessment to determine which facilities are eligible for 100% of capitation. SIGDA-GENERATE is health information system management, where the systems in health offices, hospitals, clinics, both public and private, are integrated and data entry is standardized to increase accountability. These are several innovations that Indonesia has undertaken to respond to challenges in private primary healthcare regulations to engage with private health sector.
Thank you, Rizky, for sharing some of Indonesia's innovations. Additional innovations that resulted from this collaborative joint learning exercise include prioritizing government budgets for regulation by including them as line item budget. Both Malaysia and Mongolia have shared their experience with this in the report available online. Now, another innovation discussed in the synthesis report is the translation of regulations to operating procedures or implementation guidelines at the subnational levels to ensure that the practical applications of laws and regulations are successful. And finally, several countries have focused on increasing awareness among the public as well as among the healthcare providers on their rights and obligations by strengthening strategic communication around regulatory requirements. Now, at this time, we would like to pause for a few minutes to take questions from our webinar participants. Please submit your questions through the Q&A box in WebEx. We have several of the country experts online, and they will do their best to answer your questions. Any questions not addressed during this webinar may be addressed via email or in a follow-up blog post. Okay, now the first question. Oh my. It's to Kenya, I think. 1 minute. From Kenya, from Julia. The question is to the Malaysian team. What exact activities is Malaysia looking at to implement regulation? Dr. Shafi'i, are you on the line? Dr. Shafi'i? Can Alina get Dr. Shafi'i on the line, please?
We have Dr. Shafi'i on the line, but I'm not sure he's not answering. So let's move on to the next question.
Okay, so the next question, hold on. I seem to be struggling with my questions. Okay. We have a question for Kenya. Can we have a copy of the joint health inspection list? Can I invite the Kenyan panelists?
Yes, Charles Kandia from Kenya. Yes, we can avail the joint health inspection to those who would like to have, and if I can get their emails, especially from Dominique Freire, yes, we can give you, we can share with you the joint health checklist inspection.
Thank you so much, Charles. Thanks. I'm sure they will be looking forward to getting the list from you. Let me see if there are any other questions. Okay. Right. I know that the Indonesian and the Kenyan and the Malaysian team are on the line. Okay. So anyway, while waiting for further questions to come, one of the questions that we often get asked is, if my country is considering integrating private PhD providers in a government scheme and will need to begin credentialing providers, what's the best way to get started? Is there anyone I can turn to for help? Well, the government stewards can start by reviewing these knowledge products that are already available in the web. They can also reach out to the JLN, who can connect them with the JLN member countries who develop the work or have some experience in this area. There is a further question for Rizky from Indonesia. What other institutions are involved in empanelment, working with BPJS? Also, is KBK fair for Eastern districts? This sounds like an Indonesian who knows, or a non-Indonesian who knows Indonesia very well. Isn't there an appearance that KBK is increasing inequities, and what is BPJS doing to adjust? Rizky, did you get that question?
Hello? Yes.
Okay.
Yeah, thank you for the question. Yeah. So I don't really get what this empanelment mean, but maybe what I assume that in order to implement the regulation, BPJS work with other institutions to make sure that the regulations are implemented in a way that it has to be expected effectively and efficiently. So BPGS uh, um, BPGS are delegating BPGS is delegating its tasks to regional BPGS. So there are BPGS offices in each region across the nation. And in order to perform their duties, they work with, for example, in regional level, they work with health offices, for example, particularly for credentialing process. And also BPGS collaborates with other organizations such as professional organizations, and then professional organizations such as Indonesian Medical Association. Indonesian Medical Association itself has branches across the nations. So yeah, because we are decentralized, Indonesia is decentralized country. That's how it works. Even though there is a central office in the capital of the nation, but they have like the representatives in the regions. And about the commitment-based capitation, or you can say in Indonesia, KBK, I think in the regulation, which is BPGS, joint regulation BPGS with the Ministry of Health, there are several terms and conditions that health facilities must that must be met by the health facilities in order to this sort of capitation can be applied effectively. For example, a health facility that can be paid using KBK, only a health facility who has more than or similar to 5,000 members or patients, or members in the facility, in a facility. And then I think KBK itself is not applied to health facilities located in remote regions, for example, in eastern part of Indonesia, like Papua, for example, where the health facilities are scarce in that area, and probably located in remote areas. So KBK is not applied to those kind of facilities. Thank you.
Okay. Thank you so much, Rizky. That's a really great answer. Now we have a question for Malaysia. I hope Shafi'i will be able to speak. We had one question from Julia just now regarding what are the specific activities that Malaysia is doing. And the second question is, how does this effort, after learning about your lessons learned as well as the innovations that have been identified, how does it fit in with the larger thinking about development in the health system for the future? Maybe because of the maybe the thinking towards purchaser-provider split. Dr. Shafi'i, over to you.
Yeah, thank you, Dr. Kamala. Can you hear me?
Yes, go ahead.
Sorry, because I'm a problem with the, I don't know where to unmute the system.
Okay. Okay.
All right. Okay. For the first question, I think there's so many activities. I think in the time that I have, I think the main thing about specific activity probably focusing on we're trying to review some of the regulations which is outdated is one other example, and also to address the issue raised by the private sector, because we have engagement with the private sector, and then they highlight some of the issues that need to be urgently addressed by the regulator, which is, of course, in our country is the Ministry of Health. So it is our priority because some of the laws and regulations are outdated, and also some of the things which are very, we say, double standard, meaning you impose certain thing which is so high standard on the private sector, but at the same time you are not actually looking at a similar standard for the public sector. So I think these are some of the example, and I can explain more through email to Julia later if she needs to know more on the more activities, specific activities regarding the regulations. And for the second questions regarding the how does it fit with the future development of purchaser provider split? I think one of the important issues that we would like to ensure is the quality and standard of care among the providers. So in our case, for the Ministry of Health, we have some mechanisms to ensure this standard, but for the private sector, we have very little information, and we can assure that they are actually up to the standard that we expected. So this is one of focus area. We would like later, if we would like to purchase from the providers, we have to ensure that they have certain standard, and we can assure that the services that are provided and of the quality and also safe to the patients.
Okay, thank you, Dr. Shafi'i. Yes. I have a question now for all the panelists. I don't know whether Julia, if you're on, or is it Charles from Kenya, Rizky from Indonesia, and Dr. Shafi'i again from Malaysia. All of you have identified gaps in the capacity of the health sector in terms of regulations and enforcement. Now, how have you addressed these gaps? Can we start with Kenya?
Okay, thank you very much. In Kenya, the gaps that we had were, for example, we have got a fragmented regulation by various disciplines in the health sector, and this creates a burden, and especially of the cost of doing business, particularly for the health facilities which are multidisciplinary. They have the cost of care is mainly because many players, particularly the regulatory bodies, going there quite frequently. So by that, we identified what Julia talked about earlier, of coming up with a way of bringing together regulatory bodies to undertake inspection together jointly, or using one officer doing inspection across all areas in our facility and doing it once. So that is one methodology. The other aspect is we have regulatory bodies, and they need to go to every health facility. So we want to find, we are just coming up with the ways of how to team up with sub-nationals, that is the counties, so that they can help us, they can help the regulatory bodies be able to address, to be able, once they go to the ground and close a facility or help tell a facility to improve on certain areas, the sub-nationals or the counties are able to implement that or enforce it, because they are all the time on the ground, so that it doesn't look like you are popping there, closing facilities and then leaving to another. So those are the two areas I can say that we have gaps, and we have found solutions for them. But of course, the issue of inadequate funding, which is a gap for us, but we are still working out on how to address them. Still, we are mobilizing for resources to help us on that one.
Thank you, Charles. Now, if I can turn to Rizky. We've heard about Indonesia's innovations, yeah, and you have many actually. But there is still a question here. If you can give us a short answer, and maybe later you can follow up with more details, is does Indonesia have existing data privacy laws? How did the Indonesian team make sure that they could undertake data sharing agreements securely without sacrificing health data privacy and confidentiality? Rizky, if you could give us a short answer first.
Yeah, that's a quite difficult question actually. Well, I think that in practice, all data that are provided by health facilities to the authorities like BPJS or the Ministry of Health or for regional health offices, they are how do you say it, secured, something like that, because the data or the information itself was sent through like a special software or information system, which guarantee that the information would not be leaked to to unresponsible people, something like that. I think that's the only thing that I can answer for now, because for now, up to now, I still haven't heard something or issues around the leaked information that disadvantage many parties.
Okay.
And what is the next question again? Sorry.
The previous question was on legal capacity. If you have addressed gaps in legal capacity, do you think how would you address that gap? Would be, for example, would putting in lawyers in the Ministry of Health, would that be useful?
Oh, okay. So you mean the gaps in regulatory activity, something like that? Okay. Yeah. So I think, and based on our findings, there has been one challenge which affects the performance of the regulatory system. For example, like lack of resources, especially to develop and implement the regulations to subnational levels. For example, like in the Ministry of Health, there is a legal legal department special for developing the policies and regulations, and the regulations have to be translated to be well implemented in the subnational levels. Unfortunately, for so many regulations, there hasn't been enough capacity or resources to translate all national levels into the subnational levels. So to address that issue, usually regional government or regional health offices authorities will like collaborate with other parties, for example, public organizations or scholars, academics, to help them to develop what we call it the standard operating procedures.
Okay.
Yeah.
Thanks so much, Rizky. We have a follow-up question actually, and this is from Ghana to all the countries, to the whole group. In strengthening the private sector to achieve UHC, is it economically prudent to include the private sector facilities into the National Health Insurance Scheme? And this is more of with regards to sustainability of the insurance scheme in terms of financing. Maybe I can ask Shafi'i to start.
Thank you, Dr. Kamalia.
Mm-hmm.
Because we, as you know, we do not have the national health insurance in Malaysia because we are tax-based or tax-funded.
Mm-hmm.
We are using global budget, so we don't have much experience in terms of the national health insurance.
Mm-hmm.
But what I can see right now is we identify there is a gap in terms of trying to achieve universal health coverage. If we depend on the government or public facilities, I think it's very difficult to achieve that because most of the, especially in the urban area, whereby there's not many public facilities. But the people of different economic status, we have the urban poor, we have middle income group. These people actually need some sort of facility that they can go and which is affordable. So for the time being, if we are just focusing on the public sector, I think I would say it's very, very difficult, very challenging to achieve what we call it universal health coverage. Because even though they are in the urban area, there's so many private facilities, but they cannot access. But financially, is already involved. I think that's the comment I can give.
Okay, thank you, Dr. Shafi'i. I think that wraps it up very well, isn't it? To what Gina has said at the very beginning as regards to the importance of engaging the private sector in any country's journey towards UHC. Thank you for all of your questions. It's been really stimulating. And if there are any questions which have not been addressed adequately during this short Q&A, definitely we will follow up directly by email or in a post-webinar blog post. So if I can just go to my last slide, which is on the key takeaways. After all that interesting discussion, I hope you will remember these 3 takeaway messages which has evolved. Firstly, for all of us in our journey to UHC, a strong PHC is vital. And for most countries, the private sector needs to be included. They need to be engaged and effectively regulated. Secondly, the lessons learned in regulating the private PHC from these 6 GLN countries documented in these new resources are useful for other countries as well. We have more in common than we think. And I'm sure that these lessons reverberate with most of you. And a final takeaway message, the innovations in regulating PHC documented in these resources can be adapted to other countries. And especially what we have heard today from Kenya regarding a national regulatory technical committee to streamline regulatory oversight. Indonesia's developing their regulatory operating procedures at subnational levels, the use of purchasing as a regulatory mechanism, including line item budget for regulatory activities in the government budget to give it some focus, and also for the government to finance private sector credentialing and accreditation. This is the experience from Malaysia and Mongolia. And strengthening data management and data sharing, but as what the question came up just now, we have to ensure that data privacy as well, and informing the public about regulatory requirements through strategic communication efforts from both Indonesia and Kenya. I hope you have enjoyed this webinar as much as I have. And with that, I now hand over to Gina. Over to you, Gina.
Okay, thank you very much, Dr. Kamalia. Just to now close the webinar, I hope that our listeners have found the discussion useful. From my perspective, the JLN has done some really important work to take stock of some of the constraints and inefficiencies that exist to regulate the private health sector effectively. And I really appreciated hearing some of the practical approaches that countries are using to tackle these issues, such as the joint health inspection checklist that Kenya mentioned. Please remember to check out the suite of resources from the Private Sector Engagement Collaborative that you see here. Each of them can be found on the HFG and the JLN websites. So to close, on behalf of HFG and the JLN, I would like to once more thank Dr. Kamalia for her expert facilitation today, and our video speakers, Dr. Shafi, Julia, and Rizki, and our other JLN colleagues who contributed to this work and this discussion. We are also really grateful for generous funding from USAID and through the Health Finance and Governance Project and the Bill and Melinda Gates Foundation. They made the joint learning that led to the production of these knowledge products and this webinar possible. And finally, thanks to everybody who joined us today for the webinar. I wish you a good day or a good evening wherever you are.